We are going straight into the architecture of evidence-based medicine, epidemiology.
It really is the bedrock. I mean, if you feel overwhelmed by conflicting studies, new drug reports, or even just trying to understand a basic health statistic, it's probably because you haven't mastered the language of epidemiology.
Right.
These concepts, how we measure, how we design, and how we interpret, are what stand between a successful public health intervention and, well, sheer confusion.
Exactly. Our mission today is ambitious. We're synthesizing an incredibly dense, high-yield body of source material that acts as a comprehensive guide to the science. We want to arm you, the listener, with the tools to analyze medical claims, spot flaws in research, and truly become a critical consumer of health news.
And to do that without drowning in the jargon.
Yes, without drowning in the jargon.
Think of this as your personal shortcut to understanding how health science is actually practiced. We're covering the absolute fundamentals. So the mechanics of diagnostic testing, how we quantify risk,
The hierarchy of evidence, which is so critical.
the strict hierarchy of evidence, the meticulous phases of drug development, and then wrapping up with the actionable public health interventions that save lives, like, vaccination and screening recommendations. It's a comprehensive dive into data-driven decision-making.
Let's get this process started. We've got a lot of ground to cover, and we need to make sure we tackle every concept with the depth it deserves. So before we can even talk about treating or preventing disease, before we can begin to measure the success of an intervention, we just need to know how often a problem is actually happening. If we don't count correctly, we're basically basing our entire public health strategy on fiction. So what are the core metrics used to track diseases, and what is the fundamental trap in using them interchangeably?
The first, and I think the most crucial distinction we have to make, is between two terms that are so often confused in general conversation that they basically lose their precise meaning.
Okay.
And those are prevalence and incidences. If you only remember one thing from this section, remember the difference between these two.
They sound like synonyms, but in epidemiology, they are snapshots of fundamentally different concepts. One is a count and one is a rate.
Precisely. Prevalence is a measure of burden. It is a snapshot in time, the total number of existing cases in a specific population at a single defined moment.
So it gives you the full scope of the disease's presence right now.
Right now.
So if you survey a population of, say, 10,000 people today and find 100 people are currently living with multiple sclerosis, the prevalence of MS in that population is 1%.
That's it.
It's a measure of the total living cases regardless of when they got sick.
Correct. The formula is really straightforward. Prevalence equals the total number of cases in the population at one point in time divided by the total population.
Right.
And this is, highly useful for public health planning. For instance, calculating how many hospital beds or specialized clinics you might need for a chronic condition.
Okay, so that's prevalence. Incidence, on the other hand, measures new disease development. It tracks how quickly people are becoming ill.
Yes. The incidence of a disease is the number of new cases in the population that develop over a defined period of time. And critically, the denominator here is the population at risk.
The disease-free population.
The disease-free population.
Wait a minute. So when we talk about incidence,
Yeah.
we have to be absolutely sure we're not double counting, right? We only care about people who were totally disease-free at the start of that measurement period.
That's essential for accuracy.
Right.
You have to exclude anyone who already has the disease from that at-risk denominator. A patient already diagnosed with COVID-19 at the start of the month cannot be counted as a new case of COVID-19 incidence for that month.
Okay, so the formula is incidence equals the number of new cases in the population over a given time period divided by the total population at risk during that specific time period. Incidence is truly a rate of change.
And this distinction becomes vital when we look at the interaction between the two, which is often summarized by the key relationship. P equals I times D.
Prevalence equals incidence times duration.
Exactly. Prevalence P is directly related to incidence I multiplied by the average duration D of the disease.
This formula, I think, demonstrates a fascinating paradox in public health, one that often trips up public understanding of disease trends.
Let's use the classic example from our sources. Type 2 diabetes. Imagine a decade passes. The rate of people developing diabetes. The incidence I remains stable. No more or fewer new cases per year.
Okay.
But during that decade, medical advances dramatically improved treatments, extending the lives of those living with diabetes by an average of, say, 5 years.
So in that scenario, the duration of the disease increases significantly because people are living longer with the illness. Even though our primary prevention efforts haven't changed the new case rate, the prevalence, the total number of people currently living with diabetes, will spike.
So on paper, it looks like the disease burden is dramatically worse because prevalence is higher, but the increase is actually a sign of successful, life-extending medical intervention. It's a great illustration that you can't look at prevalence numbers in a vacuum.
You have to ask, is this increase due to more people getting sick, which is high incidence, or people living longer with the illness, high duration?
That's the core question.
That brings us to a practical calculation problem, especially when we're running cohort studies that last for years or even decades. You often run into the issue that not everyone participates for the exact same amount of time.
People drop out, they move.
Or, sadly, they die from other causes.
Yeah.
So how do researchers account for the time participants did contribute to the risk pool?
This is where the person-time estimate comes in, and it really refined their incidence calculation. This measure is necessary to calculate incidence accurately when patients contribute varying amounts of follow-up time. It's designed to create a very precise denominator for our incidence rate.
So it's essentially aggregating the total time the entire population was truly at risk of developing the outcome we're studying.
Precisely. Imagine we have a 10-year study. Patient A completes all 10 years and doesn't get the disease. They contribute 10 person-years of risk time.
Okay.
Patient B is in the study for 4 years and then drops out. They contribute 4 person-years.
Right.
Patient C is in the study for 8 years and then develops the disease. They contribute 8 person-years because after that point, they're no longer at risk of developing it for the first time.
So if we had 100 people enrolled, but half dropped out or developed the disease early, the total person-years might only be 600 instead of the full 1,000. Using 1,000 as the denominator would dramatically underestimate the true incidence rate.
It would completely skew the results. We need to account for the 4 major endpoints that determine how much time a person contributes: entry into the study, exit from the study, development of the disease, or the end of the study period. Using person-time estimates provides a robust, fair estimate of the incidence rate.
It ensures our denominator accurately reflects the actual time the population spent vulnerable to the disease.
That's the goal. So when we transition from measuring how often disease occurs to how we find it, we have to talk about diagnostic testing. When we design a diagnostic test, we need metrics that tell us not just if the machine works, but how reliable that test is.
For both ruling out and ruling in a condition.
Exactly. Especially depending on who we are testing.
This is where we bring in the infamous 2x2 table. This is the foundational cheat sheet for judging any diagnostic test against the gold standard, the definitive, perfect test that confirms the actual disease status.
That 2x2 table is critical because it breaks down every possible outcome into 4 categories based on the test result and the actual disease status. These 4 raw numbers are the ingredients for everything that follows.
Let's lay those out, focusing on the clinical implication of each result. First, true positive, or TP.
The test says positive, and the patient genuinely has the disease. A correct diagnosis, we can proceed with treatment.
Good. Then false negative, FM.
The test says negative, but the patient has the disease. This is a missed case, and this is a potentially catastrophic error leading to delayed treatment.
The worst case scenario, really. Okay, false positive, FP.
The test says positive, but the patient is actually disease-free. This is an error that leads to unnecessary anxiety, costly follow-up testing, and sometimes invasive procedures.
And finally, true negative, TN.
The test says negative, and the patient is genuinely disease-absent. We correctly reassured the patient, a good outcome.
So with those 4 quantities, TP, FN, FP, and TN, we can calculate the 2 core metrics that define the test itself, independent of the population being tested: sensitivity and specificity.
That's right. These are inherent properties of the test.
Okay, let's start with sensitivity. This is the test's ability to correctly identify those with the disease. The true positive rate. How good are we at catching the sick people?
The precise definition is the probability that a patient with the disease will have a positive test result. The formula is sensitivity equals TP divided by TP plus FN.
So the denominator is just everyone who actually has the disease.
The total number of people who actually have the disease, yes. The true cases.
And this is where that useful mnemonic comes in. S no ut.
S negative.
Sensitive test, negative result, rules OUT the disease. That's the clinical takeaway.
And if a test has high sensitivity, say 99%, it means it rarely misses individuals who have the disease. It has a very low false negative rate. Therefore, if a patient tests negative on that highly sensitive test, we can be fairly confident the disease is ruled out.
which is why we use them for screening.
Exactly. We use highly sensitive tests for initial screening when missing a case would be very dangerous.
Like the initial ELISA screening test for HIV infection, we have to prioritize sensitivity there because a false negative missed HIV case would have enormous public health consequences. You want that test to cast a very wide net, even if it catches a few false alarms.
That is the perfect application. And the associated error, the false negative rate, is simply 1 minus the sensitivity.
Okay, so if sensitivity is about catching flu cases, specificity is about correctly identifying the healthy people. How good are we at avoiding those false alarms?
Specificity is the probability that a patient without the disease will have a negative test result. So the formula is specificity equals Tn divided by Tm plus Fp. The denominator here is the total number of people who are truly disease absent.
And the corresponding mnemonic is SPN. Specific test, positive result, rules in the disease.
A highly specific test means it rarely labels someone who is disease-free as having the disease. It has a low false positive rate. Therefore, a positive result from a highly specific test helps you rule the disease in.
So these are used as confirmatory tests.
Right, after a sensitive screening test has flagged an individual.
Continuing the HIV example, the Western blot confirmatory HIV test is a high specificity test. Once the sensitive ELISA screen flags a potential case, the specific Western blot confirms it. You need high specificity here because labeling someone as HIV positive when they are not is a life-altering, terrible mistake.
And again, the corresponding error is the false positive rate, which is just 1 minus specificity.
Okay, we have to move past the ideal scenario where tests are 100% perfect. In reality, most medical tests measure continuous variables, like a protein concentration in the blood, and you have to draw an arbitrary line, a cutoff value. And that line inherently creates a trade-off.
This is the crucial balancing act. If you lower the cutoff value of your test, meaning a lower reading counts as positive, you increase sensitivity, you catch more true cases.
So you'll have fewer false negatives.
Right, but you immediately sacrifice specificity because you start classifying more healthy people as sick. You get more false positives.
So we make the test more inclusive but less precise.
Exactly. And conversely, if you raise the cutoff, making it harder to test positive, you increase specificity, but you decrease sensitivity. The choice of cutoff is a clinical decision based on the consequences of the errors.
Is a false negative worse, like in HIV screening, or is a false positive worse, like in screening for a rare, untreatable condition?
That's the question you have to answer. And we can quantify and visualize this trade-off using the receiver operating characteristic, or ROC curve.
So what does that actually look like on a graph?
The ROC curve plots sensitivity on the y-axis against the false positive rate, which is 1 minus specificity, on the x-axis, across every possible cutoff value. It shows you the test's performance across the entire range of possibilities.
And the shape of that curve is what matters.
The better the test, the more the curve bows toward the upper left corner of the graph, hugging the y-axis. The overall discriminating power of the test is quantified by the area under the curve.
The AUC.
The AUC. An AUC of 1.0 means perfect accuracy. You could perfectly separate the sick from the healthy. An AUC of 0.5 means the test is useless, performing no better than a coin flip. The closer the AUC is to 1.0, the stronger the test's ability to differentiate.
Okay, we've nailed the internal reliability of the test itself with sensitivity and specificity. Now we move to the metrics that actually matter to the patient sitting in front of the doctor. If I test positive, what is the chance I actually have the disease?
These are the predictive values.
Right.
The positive predictive value, or PTV, is the probability of having the disease given a positive test result. And the negative predictive value, NPV, is the probability of not having the disease given a negative result.
And here is one of the highest yield concepts in this entire deep dive. Unlike sensitivity and specificity, the predictive values are heavily influenced by external factors. This is the prevalence trap.
This is the key insight that separates an informed person from a confused one. PTV and NPV depend dramatically on the prevalence of the disease in the population being tested. If the disease prevalence decreases, the PBV decreases, and the NPV increases.
Even if the test's internal metrics, the sensitivity and specificity remain exactly the same.
Exactly the same. Let's use that neonatal screening example. Imagine a perfectly good diagnostic test with 95% sensitivity and 95% specificity. If we use this in a hospital where the disease prevalence is, say, 10% a high-risk group, the PPV might be quite good, maybe 70%.
Okay, that makes sense.
Now, we take that exact same test and use it in a general population screening where the prevalence is 1 in 50,000, a very rare disease.
Right.
Despite the excellent technical specs, the PPV, the chance that a positive result is real might drop to less than 1%.
That sounds crazy. How does a 95% specific test produce a 99% false alarm rate?
Because the denominator for PPV, which is true positives plus false positives, will be completely dominated by the false positives. You have so many millions of healthy people that even a 5% false positive rate applied to that huge group generates thousands of false alarms. Meanwhile, the true cases are extremely rare.
So a positive result in a low prevalence population doesn't really rule the disease in very well. It just means more testing is needed to confirm.
Precisely. This is why testing for rare diseases in the general population often results in very low PPVs, causing a lot of stress and unnecessary cost. Conversely, the NPV, the NAM chance a negative result is correct, is extremely high when the disease is rare, which is reassuring. And because PPV and NPV are so dependent on the pre-test probability, the prevalence, we often turn to something called the likelihood ratio, or LR.
Let's think of the LR as the multiplier, the factor by which the test changes the probability of diagnosis.
That's a great analogy. It expresses the change in odds. If I already thought a patient had a 10% chance of being sick and they take a test, the LR tells me how much to adjust that 10% belief based on the result.
So it's more dynamic.
Much more dynamic. We have two key ratios, LR positive and LR negative. LR positive shows how much the odds of disease increase if the test is positive. A high LR positive, usually over 10, means a positive result is very powerful for ruling in the disease.
And LR negative?
LR negative shows how much the odds of disease decrease if the test is negative. A very low LR negative, usually less than 0.1, means a negative result is very powerful for ruling out the disease.
So if a test has an LR positive of 10, that positive result just made me 10 times more confident that the patient is sick than I was before the test. And if it has an LR negative of 0.1, the negative result means I'm 10 times less confident they have the disease. That flexibility is incredibly valuable.
It is. It allows clinicians to integrate the test result with their existing clinical judgment or the known prevalence using a simple formula. Post-test odds equal pre-test odds multiplied by the likelihood ratio. It moves the diagnostic process from a fixed number to a dynamic probability based on the patient's context.
Now that we know how to measure how often disease occurs and how good our diagnostic tools are, let's look at the relationship between an exposure like smoking or a specific medical intervention and an outcome like heart disease or cancer. We need robust ways to quantify that risk relationship.
Right. This section is all about determining causation and clinical impact. It answers the question, does this intervention matter? And if so, how significant is the change in risk? We can start with absolute risk, which is simply the incidence of disease in a specific group. So when we run a cohort study, we compare the incidence in the exposed group to the incidence in the unexposed group.
And the most commonly cited measure in the news is the relative risk, or RR. This tells us about association.
Relative risk expresses how much more or less likely an exposed person is to get the disease compared to an unexposed person. The formula is pretty simple. RR equals the incidence in the exposed group divided by the incidence in the unexposed group.
Let's look at the structure using that exposure versus disease development 2x2 table again. A is exposed and diseased, P is exposed and not diseased.
C is unexposed and diseased, and D is unexposed and not diseased. So the RR calculation becomes the incidence in the exposed, which is A divided by A plus B, all divided by the incidence in the unexposed, C divided by C plus D.
And the interpretation is straightforward but crucial. If the RR is 1.0, there is zero association. If RR is greater than 1, the exposure is associated with an increased risk.
Like smoking and lung cancer.
And if RR is less than 1, the exposure is protective, like taking statins and avoiding heart attacks. This is the cornerstone measure for cohort studies.
That's right.
But relative risk is great for showing how much more likely, but it can be misleading in terms of real-world impact. If a drug doubles your risk of a rare condition, an RR of 2.0, that sounds terrifying. But if the baseline risk is 1 in a million, doubling it means you now have a risk of 2 in a million, which is a very low absolute increase.
That's exactly why we need attributable risk, or AR, sometimes called the risk difference. AR tells us the absolute difference in risk between the exposed and unexposed groups.
So the formula is just incidence in exposed minus incidence in unexposed.
That's it. And this number is critical because it represents the risk directly attributable to the exposure itself. It's the portion of the disease we could eliminate if we remove the exposure.
Okay, so if the incidence of lung cancer in smokers is 15 per 1,000 and the incidence in non-smokers is 2 per 1,000.
The attributable risk is 13 per 1,000. That's the absolute excess risk specifically due to smoking.
And the attributable risk percentage then tells us what percentage of the disease incidence in the exposed group is due to that exposure.
Yes. ARP is calculated as the RR minus 1 divided by the RR, all times 100%. This provides the clinician and the public health official with the impact quantification, the proportion of cases you could prevent by removing the exposure from the exposed group.
When we talk about beneficial treatments, we flip the language from attributable risk to absolute risk reduction, or ARR. This is the practical difference the intervention makes.
ARR is the difference in risk that is attributable to the intervention compared to a control group. So if a medication reduces the risk of stroke from 10% in the control group to 4% in the treatment group, the ARR was 6%, or 0.06.
ARR is essential, but I think the number needed to treat, the NNT, is the most clinically actionable number derived from this entire section.
The NNT is the metric that forces value judgments in healthcare. It answers the question, how many patients do I need to treat with this intervention over a given period to prevent one single adverse outcome?
And it's simply the inverse of the absolute risk reduction.
NNT equals 1 divided by ARR.
Let's work that example. If the ARR is 6%, or 0.06, the NNT is 1 divided by 0.06, which is approximately 17. So you must treat 17 people with that new drug to prevent one single stroke.
Right. Now compare that to a hypothetical chemotherapy drug where the ARR is 50%, meaning the NNT is 2. You only need to treat 2 people to save 1 life.
And that high impact might justify severe side effects and high costs.
Exactly. But if the ARR is 0.5%, the NNT is 200, that low benefit might not justify a high cost or even mild side effects. NNT forces the clinician and the patient to weigh the individual cost and benefit.
So as we discussed, relative risk, or RR, is the measure for cohort studies. However, when we perform case control studies, which look backward in time, we can't calculate true incidence.
We can't because we select people based on their outcome, whether they're sick or healthy. Therefore, we have to rely on the odds ratio, or OR.
And the odds ratio represents the odds of exposure among cases versus the odds of exposure among controls. It's an estimate of relative risk.
The formal definition is the odds that a diseased person is exposed, divided by the odds that a non-diseased person is exposed. Using that ABCD matrix, the calculation is often performed as a cross multiplication. A times D divided by B times C.
So why do we accept the OR as an estimate?
Because case control studies are designed to be efficient for rare diseases. But since we can't calculate the population at risk over time, we can't calculate true incidence, or RR. The critical approximation rule allows us to use the OR.
What's the rule?
When the disease being studied is rare, so the incidence is generally less than 10%, the odds ratio closely approximates the relative risk.
Which is why OR is the default measure for retrospective studies of rare drug side effects or rare cancers, where setting up a long-term cohort study would be, well, just infeasible due to cost and time.
Exactly. Let's walk through the sample calculation provided in our source material. We have a hypothetical case control study. Cases exposed, A is 283. Cases unexposed, C is 263.
Okay.
Controls exposed, B is 182, and controls unexposed, D is 210.
So plugging those numbers into the OR formula, we have 283 times 200 divided by 182 times 263.
Right. The numerator is 59,430. The denominator is 47,866. And that yields an odds ratio of approximately 1.24.
So the interpretation is that the exposed group had 1.24 times the odds of having the disease compared to the unexposed control group.
That's right.
Finally, we have the hazard ratio, or HR, which is used primarily in prospective studies and clinical trials that deal with time-to-event data.
Right, like a Kaplan-Meier survival curve.
Yeah.
The HR is an estimate of the chances that an event, like death or cancer recurrence, occurs in the treatment arm versus the non-treatment arm at any given moment in time. It's a ratio of hazard rates.
So this is more dynamic than the RR, which only provides a risk for the entire study duration. The HR captures the instantaneous risk over the entire follow-up period.
Exactly. If a study concludes with a hazard ratio of 0.7, it means that at any given time point, the treatment group has a 30% lower chance of experiencing the event compared to the control group. If the HR is 1.0, the hazards are equal.
So less than 1 is protective, greater than 1 increases risk.
It's crucial for studies where survival time is the primary endpoint. We have mastered the math. Now we have to shift to methodology. Not all evidence is created equal. If you see two studies contradicting each other in the news, one claiming a new diet works, another claiming it's useless, how do you know which one to trust?
And the answer lies in the study design.
It does.
Understanding the methodology is the single most important tool in evaluating the strength of any medical claim. We need to look at the hierarchy of evidence, from the quick and dirty snapshot to the definitive gold standard.
When we talk about the evidence pyramid, we are visually representing the reliability of research. The least reliable studies are at the bottom, and the most reliable are at the top, because studies higher up are designed to minimize bias more effectively.
So at the very base, we find things like expert opinion, anecdotal evidence, and editorials. Slightly higher are case reports and case series single patient stories or small collections.
Right, and these are useful for flagging novel diseases or rare side effects, but they only generate hypotheses. They can't prove causality.
Okay, what's next?
Moving up, we encounter the three main types of observational studies we've been talking about: cross-sectional, case control, and cohort studies. These observe associations, but because the researcher doesn't manipulate the exposure, they're highly susceptible to bias and confounding variables.
Then we reach the top tier, the filtered information, which is designed to minimize error. The randomized controlled trial, the RCT, is the gold standard for testing a treatment, sitting near the top.
But even above the individual RCT are the syntheses, the systematic review, which is a rigorous, structured assessment of all relevant studies on a topic.
And the meta-analysis, which sits at the very peak. Why is that considered the strongest evidence?
Because a meta-analysis takes the data from multiple high-quality RCTs that address the exact same question and statistically combines them. By pooling results, you dramatically increase the sample size and gain immense statistical power.
So it washes out random errors from individual trials?
Exactly. It gives the most reliable overall conclusion about causality and effect size, but it is also the most resource-intensive to perform.
Let's start with the simplest form of rigorous study, the cross-sectional study. This is characterized by being a single, immediate snapshot in time.
The purpose is to assess risk factors and outcomes simultaneously at that one point in time. Because it's a snapshot, it can tell you the prevalence of a disease. For example, surveying 1,000 residents today to see how many use nicotine and how many have hypertension.
But the drawback is immense, right? We can't determine causality.
We cannot.
Yeah.
We don't know if the person developed hypertension and then started smoking due to stress, or if the smoking caused the hypertension, or if some third variable caused both. It's impossible to determine the temporal sequence.
The advantages are efficiency, though. They're quick, they're inexpensive, and they're great for public health surveys and just generating hypotheses.
Yes, and they're also used to validate diagnostic tests. But their defining disadvantage is that inability to measure incidence or establish causal relationships. They're purely associative.
Okay, moving up the hierarchy. The cohort study offers a much stronger level of evidence because it tracks the temporal relationship between exposure and outcome. This is where we follow a large crowd over time.
A cohort study assembles groups, one exposed to a factor, say radiation, and one unexposed, and follows them over time to determine the incidence and outcomes of interest.
And since they move forward in time,
They allow us to calculate the relative risk and attributable risk.
the quintessential example is the Framingham Heart Study, which started in 1948 and is still running. It assembled a cohort and tracked lifestyle factors and blood metrics to directly observe the development of cardiovascular disease over decades.
The advantages are profound. They directly determine incidence, they track development over time, establishing temporality, and a single exposure, like Agent Orange, can be tracked for many different outcomes simultaneously.
The disadvantages, though, are proportional to their quality. They are time-consuming and astronomically expensive.
Very expensive. And they're not practical for studying rare diseases. And they are severely impacted by loss to follow-up, which can introduce bias if the people who drop out share common characteristics.
Okay, so if the cohort study looks forward, the case control study looks backward. And this is the most efficient design for tackling rare outcomes.
In a case control study, researchers identify cases, people who have the rare disease, and then match them with controls, people who are disease-free, and look retrospectively at their frequency of exposure.
We're comparing the frequency of exposure in diseased people versus non-diseased people.
Which is inherently efficient and cost-effective. You use smaller groups than cohorts, and you can examine multiple risk factors for a single rare disease.
A key concept here for minimizing confounding is matching.
Yes. To control for variables that might skew the results like age or sex, researchers often match controls to cases, often in a ratio of 1:1 up to 1:4. This ensures that the two groups are comparable in every way except for the disease itself.
Which increases the likelihood that any difference in exposure is meaningful.
Right. But the disadvantages of looking backward are substantial. You can't calculate true incidence or prevalence. And crucially, they are highly susceptible to recall bias.
Right. If a patient has a rare neurological disorder, they might exaggerate or remember exposures differently than the healthy control, which would skew the reported association. And so we arrive at the pinnacle of evidence for treatment efficacy, the randomized controlled trial, or RCT. This is the only type of study that allows us to confidently claim causality.
The RCT is the gold standard because its design minimizes every source of error we've discussed so far. Subjects are randomly assigned to a treatment arm or a control arm.
Randomization is the magic key.
It is.
It means that any known or unknown confounding variables, age, diet, genetics, socioeconomic status, are distributed equally across the groups. This balances the playing field, making the groups statistically identical except for the intervention itself.
And that's what allows us to say the difference in outcome must be attributable to the intervention. The other key technique is blinding.
Right. Single blinding where patients don't know their group, or double blinding.
Double blinding, where neither patients nor the treating physicians know, prevents observer and placebo biases from affecting the outcomes.
Imagine a trial studying a new drug for multiple sclerosis. The groups would be randomly assigned and double-blinded, ensuring that the physician doesn't unconsciously treat the known drug recipients with extra enthusiasm or interpret their symptoms more favorably.
Exactly. But despite being the best method for testing treatment efficacy, RCTs are not a perfect solution. They are costly, time-intensive, and sometimes simply unethical.
You can't ethically withhold a known effective treatment with a placebo.
You can't. And they're also often not feasible for complex surgical interventions.
Okay, to bring this section home, let's quickly synthesize the comparison of these four designs. Knowing what a study can and cannot tell you is the core of this section.
Let's start with what they measure. RCTs measure causality and effect size, RR, HR, and NT. Cohorts measure association, risk factors, and incidence, RR and AR.
Case control studies only measure association using the odds ratio, the OR.
And cross-sectional studies measure prevalence. That's it. The design is the critical differentiator. RCTs use random assignment. Cohorts simply follow groups over time. Case control studies identify outcomes first, then look backward.
And cross-sectional studies look at exposure and outcomes simultaneously.
Right. And remember the biggest weaknesses. RCTs are constrained by ethics or cost. Cohorts are slow and lose people to follow up. Case control studies are crippled by recall and selection bias. And cross-sectional studies cannot establish temporality or causality. Understanding these limitations informs your trust in the study's conclusion.
A medical breakthrough only matters if the study producing the results is valid and reliable. So we need to understand the rigorous journey a drug takes to gain approval, and then, most importantly, how to spot the various systematic errors we collectively call bias.
The journey of a new drug is a gauntlet, a highly structured progression to ensure both safety and efficacy are tested incrementally before public release. This process begins with preclinical work.
Preclinical work involves testing in the lab using animals or in vitro experiments to understand the basic mechanism of action and toxicity. If the drug is too toxic or ineffective at this stage, the journey just ends there.
Right, but if it clears that hurdle, it moves to humans, starting with phase 1. The goal here is fundamental safety and dosing range. It involves a very small group, typically 10 to 100 participants, who are generally healthy volunteers.
So phase 1 is just about safety, not if it works.
Just safety. We're only checking if it's safe to proceed. About 70% of potential drugs advance past this stage. The drug then enters phase 2, where the crucial question is efficacy.
Does it work?
Phase 2 assesses therapeutic efficacy and common adverse effects. The participant pool grows to 100 to 300 individuals, and importantly, these are patients who actually have the disease the drug is intended to treat.
So we're looking for the first evidence of benefit.
Yes. This phase is notoriously challenging, with only about 33% of drugs advancing. If it doesn't show promise here, it's typically scrapped.
Okay. Phase 3 is the definitive, expensive step that confirms everything in a large, diverse population.
Phase 3 confirms effectiveness, monitors side effects across a much broader demographic, and compares the drug to the current gold standard treatment. This phase involves a massive pool, often 300 to 3,000 patients with the disease.
And this leads to regulatory approval.
Successful completion leads to the submission for regulatory approval, like from the FDA. This trial is where the evidence used in the final drug label is generated.
And even after approval, the drug development journey isn't over. That brings us to phase 4.
Phase 4 is post-marketing surveillance. This involves potentially millions of patients taking the drug once it's commercially available. The goal is to detect rare, long-term adverse events that might only appear with massive exposure.
Like a severe side effect that affects 1 in 10,000 patients, you'd miss that in a phase 3 trial of 3,000.
But will certainly surface once millions are taking the medication.
Okay, so no amount of careful planning can eliminate the possibility of systematic error or bias, which results in an incorrect assessment of the truth. We need to be vigilant about identifying where the results might be misleading.
Let's detail the major forms of bias, as they are the primary reasons observational studies sometimes reach contradictory conclusions.
Let's start with selection bias.
Selection bias occurs when the method of sampling or participant selection skews the results, making the sample unrepresentative. For example, if a study on hypertension only recruits patients from a high-income clinic, the results might overestimate the effect of a certain risk factor that is prevalent in that demographic.
The key defense is strict representative inclusion criteria.
Exactly. Then there is measurement or observer bias.
So this comes from the data collection process itself.
Yes. For example, if researchers use a scale that consistently overestimates weight by 5 pounds for one group, but is accurate for the control group, observer bias is more subtle. It occurs when a researcher's knowledge of the treatment arm subtly affects how they administer treatment or interpret subjective results.
Which again underscores why double-blinding is the gold standard.
Really does.
Recall bias is a massive issue, particularly in case control studies that look backward.
Recall bias occurs when the ability to remember past facts differs between cases and controls. A person diagnosed with Parkinson's disease, the case, might spend weeks trying to recall every pesticide or chemical exposure from their life.
While a healthy control might just give a vague, cursory answer.
Right. This enhanced recall among the cases exaggerates the perceived exposure frequency, creating a spurious link between the exposure and the outcome.
And we have to mention the classic psychological bias, the Hawthorne effect.
This is when subjects change their behavior simply because they know they are being observed. If workers know they are being studied for productivity improvements, they will temporarily boost their output. This makes the intervention look incredibly beneficial, even if the effect vanishes once the study concludes.
Now let's tackle the most complex confounding bias and distinguish it from effect modification.
Confounding occurs when a third variable is independently related to both the exposure and the outcome, creating a false or incorrect association.
The classic fisherman example.
Exactly. If you study fishing and lung cancer and find an association, the confounder is the high prevalence of smoking among fishermen. Smoking is the true cause. But if you don't account for it, fishing looks guilty.
How does that differ from effect modification?
In effect modification, the third variable changes the strength of the true association. The association exists, but its magnitude depends on that third factor.
Okay, an example.
A treatment might be 80% effective in men under 60, but only 10% effective in women over 60. Age and sex are not confusing the results. They are genuinely modifying the strength of the treatment effect. The treatment works strongly in one group and weakly in the other.
And finally, we need to address two biases unique to screening programs, lead time bias and link bias.
Lead time bias gives the appearance of prolonged survival when the natural course of the disease is unchanged. If a screening test finds cancer 5 years earlier than symptoms would have, the patient appears to live 5 years longer, even if their actual lifespan is the same. The time gain is only in diagnosis, not survival.
And length bias is sometimes called the slow grower bias.
Yes. Screening preferentially detects slowly progressing, less aggressive cases because those tumors stay in the detectable phase for a longer period of time. You're more likely to catch the slow, fat fish swimming near the surface.
So the fast, aggressive cases may grow too quickly to be caught by the screening.
Exactly. This makes the screening program appear more beneficial than it truly is because you are disproportionately measuring survival among the less lethal cases.
Once we've designed the study and minimized bias, we have to deal with chance. Since we rarely test entire populations, we use statistics to determine the probability that our observed results are real or merely due to random chance variation. And this introduces the concept of statistical errors.
Every test begins with a null hypothesis, the assumption that there is no difference between the groups. We're testing to see if we have enough evidence to reject that assumption.
Okay, type I error, or alpha, is the risk of false hope.
A type I error is the probability of concluding that there's a difference or effect, rejecting the null hypothesis, when in reality there is none. This is a false positive finding.
And the p-value quantifies this risk.
The p-value is the probability of committing this error. If we set alpha at 0.05, we accept a 5% risk of finding a significant difference when one does not exist. The consequence of a type I error is often wasted research resources and pursuing ineffective treatments.
But the p-value doesn't tell us how big the effect is, only if it's likely real.
Exactly. It speaks only to the role of chance. The second risk is the type 2 error, or beta, which is the risk of a missed opportunity.
The type 2 error is failing to reject the null hypothesis when it is, in fact, false. You miss a true effect. This is a false negative finding.
And the consequence here is that a potentially life-saving drug might be incorrectly dismissed as ineffective.
And the power of a study is directly related to this.
The power of a study is calculated as 1 minus beta. If a study has high power, typically 80% or greater, it has a low risk of a type 2 error. The primary way to increase a study's power is by increasing the sample size.
Larger studies are better equipped to detect a true difference, especially when that difference is small.
Right.
Finally, let's emphasize the confidence interval, the CI, which is often far more informative than the p-value alone.
The confidence interval expresses the range of true values within which the true population parameter lies, usually 95% of the time.
Yeah.
A narrower CI indicates greater precision. If a study reports a difference with a very wide CI, it suggests low precision, possibly due to a small sample size.
And the CI provides an instant, crucial check on statistical significance for measures like RR or OR.
Yes. If the 95% CI for a relative risk or an odds ratio includes the value 1.0, the results are not statistically significant.
Because 1.0 means no effect.
Exactly. So if the CI spans 1.0, the researchers cannot rule out the possibility that the true effect is 0. For example, if a trial reports an RR of 1.5 for a side effect, but the CI is 0.8 to 2.2, the results are non-significant because 1.0 is included.
The treatment might increase risk, decrease risk, or have no effect.
But if the RR was 1.5 with a CI of 1.1 to 1.9, the result is highly significant.
Okay, so once the data is collected, we need the right statistical tool based on the nature of the data, numerical or categorical, and the number of groups being compared.
First, you start by summarizing the data with descriptive statistics: the mean, median, mode, standard deviation, and range.
Then, when comparing groups of numerical data, we choose between the t-test and ANOVA.
If you're comparing the means of two large independent groups of numerical data, you use the t-test. But if you're comparing the means of 3 or more groups,
like the average survival rate across 3 different drug regimens,
then you use the analysis of variance, or ANOVA. ANOVA determines if there is a statistically significant difference among the overall group means. It flags that at least one group differs from the others.
And when dealing with categorical data proportions or frequencies, like disease present versus absent, we use the chi-square test.
For categorical data comparing 2 or more variables, if the sample size is large enough, use the chi-square test. This tests whether the observed distribution of outcomes differs significantly from the distribution you would expect by chance.
Finally, let's quickly differentiate correlation from regression. They're often conflated.
Correlation just measures the degree to which 2 variables are related. They move together. Regression is a more powerful tool used to predict one variable's value based on the value of 1 or more independent variables. Linear regression predicts a continuous outcome, like predicting cholesterol level. Logistic regression is used when the outcome you're predicting is categorical, like predicting the presence or absence of heart disease. We shift gears now from the rigorous statistical analysis to the actionable steps taken in public health. This is about applying all that knowledge to real-world efforts, preventing disease, immunizing populations, and setting up effective screening programs.
We classify disease prevention into 4 distinct levels, each targeting a different point in the disease timeline, from before the disease even exists to after the damage is done.
Primary prevention is the ideal. It includes measures that reduce the incidence of disease in individuals who are currently unaffected. The goal is to eliminate risk factors and stop the disease before it ever starts.
So things like promoting exercise, counseling patients on reducing alcohol intake, wearing seatbelts.
And most famously, vaccination.
Okay, next, secondary prevention, which focuses on people who may have the disease but are not yet symptomatic.
Secondary prevention focuses on the early diagnosis and treatment of asymptomatic or mild disease to halt its progression. This involves screening tests designed to identify subclinical disease, so pap smears, mammograms, or routine blood pressure and cholesterol screening. You're aiming to catch the disease early enough to intervene effectively.
If the disease has already occurred and become symptomatic, we move to tertiary prevention.
Tertiary prevention aims to reduce the morbidity or mortality after the disease has occurred, minimizing the damage. This includes comprehensive measures like rehabilitation after a major stroke or using tamoxifen as an adjuvant therapy in a breast cancer survivor to prevent recurrence.
And finally, a growing concern in modern medicine, quaternary prevention.
Quaternary prevention is all about minimizing harm from unnecessary or excessive medical interventions. In a system prone to overdiagnosis and polypharmacy, this is essential. An example is the thorough medication review for an elderly patient to reduce drug interactions and prevent unnecessary side effects.
Vaccination is the cornerstone of primary prevention, and the technology involved is incredibly diverse, categorized into 6 major types based on how they deliver the antigen.
First, live attenuated vaccines. These use a weakened but still living form of the virus or bacteria. They provide a strong, long-lasting immune response, often mimicking a natural infection.
Examples.
Measles, mumps, rubella or MMR, Sabin polio, and varicella.
Okay, then, inactivated or killed vaccines.
These use a whole pathogen that has been killed. They were safer for immunocompromised individuals because they can't replicate, but they typically require multiple doses or boosters. Examples are Salk polio, hepatitis A, and the traditional flu shot.
Toxoid vaccines.
These target the toxins produced by the bacteria rather than the bacteria itself, using inactivated bacterial toxins. Diphtheria and tetanus are the classic examples.
Not subunit vaccines.
These use only specific protein components of the pathogen that are highly immunogenic. Hepatitis B and pertussis are good examples.
How'd you get vaccines?
These are designed primarily for young children. They link a weak antigen to a strong protein carrier to boost the immune response. Examples include the HEP vaccine and vaccines against streptococcus pneumonia.
And finally, the newest category, RNA-based vaccines.
These deliver messenger RNA to cells, instructing them to produce a harmless piece of the viral protein to generate an immune response without ever introducing the virus itself. The Pfizer and Moderna COVID-19 vaccines fall into this group.
We have to emphasize the critical clinical constraint regarding live vaccines.
Absolutely. Live vaccines should generally not be administered to immunosuppressed patients, so those on chemotherapy, high-dose steroids, or people with HIV/AIDS with low CD4 counts, or to those who are pregnant. Because the pathogen is live, there is a theoretical risk of uncontrolled infection.
But there's an exception for MMR.
Yes, the one important exception is that MMR may be given to HIV/AIDS patients if their CD4 count is above a certain threshold, typically over 200.
The recommended schedules are highly structured depending on age, prior history, and underlying medical risks. Let's walk through some of the key adult recommendations.
Well, the annual vaccine is influenza, recommended for all age groups, typically in the inactivated form. And the Tdap schedule is also a constant necessity.
Right. Tdap is required every 10 years as a booster.
Yes, for tetanus and diphtheria protection, with one of those boosters, including pertussis. And importantly, one dose of Tdap is recommended during each pregnancy, regardless of the 10-year interval, to ensure the fetus receives maximal passive immunity.
What about shingles and chickenpox protection?
Varicella, or chickenpox, vaccine is given in 2 doses to adults born after 1980 who lack proof of immunity. Zoster, or shingles, vaccine is recommended for all immunocompetent adults starting at age 50, given as a 2-dose series.
And HPV vaccination has also expanded its age range.
The human papillomavirus, or HPV vaccine, is recommended for adolescents and individuals through age 26, but it is now also approved for shared clinical decision-making with patients up to age 45, especially those who may not have been fully vaccinated previously.
And the pneumococcal vaccines are where the recommendations get a bit complex.
They do. Pneumococcal vaccination is vital for preventing pneumonia. Older adults, generally 65 and up, often receive a dose of the newer PCV20 alone, or a dose of PCV15 followed by the PPSV23 vaccine 1 year later. But those with chronic conditions like heart or lung disease may require the pneumococcal vaccine much earlier than age 65.
Routine health screening is the core of secondary prevention. It's often the single most effective tool for preventing mortality from common diseases, but the recommendations shift dramatically based on age, sex, and risk factors.
Cardiovascular screening is a big one. Blood pressure screening is essential, recommended at least once every 2 years for all adults. Cholesterol screening should begin around age 20, generally every 3 to 5 years, becoming more frequent for men over 35 and women over 45.
Okay, reproductive screening for women.
Cervical cancer screening using Pap testing starts at age 21. If testing is normal, Pap testing alone should be done every 3 years until age 30. Starting at 30, co-testing with Pap and HPV should be done every 5 years, and screening generally stops around age 65 if prior tests were adequate and normal.
And mammograms.
Mammogram recommendations for breast cancer screening typically begin between ages 40 and 50, depending on the professional organization and patient choice, but are consistently recommended every 1 or 2 years thereafter until age 75.
What about reproductive screening for men and STIs?
Routine HIV screening is recommended at least once for all adults, with more frequent testing based on risk factors. Syphilis, gonorrhea, and chlamydia testing is also risk factor driven. Prostate cancer screening, using the DRE and PSA test, is generally a discussion initiated around age 40 to 50, based on risk and shared decision-making with the physician.
Because the benefits of early screening have to be weighed against the risks of overdiagnosis.
Exactly. Other key screenings include diabetes screening, which begins if the patient is overweight and has other risk factors, or if their blood pressure is 135/80 or higher.
Colorectal cancer screening has recently become a major focus, with guidelines now recommending starting the screening process at age 45 for individuals at average risk.
Yes, and there are several equally acceptable options for colorectal screening. Fecal occult blood testing yearly, flexible sigmoidoscopy every 5 years, or the current preferred gold standard, a colonoscopy every 10 years.
And there are 2 very specific high-yield screening items for specific risk groups.
Yes. For men aged 65 and older, a one-time screening for abdominal aortic aneurysm, or AAA, using ultrasound is mandatory if they have ever smoked or have a family history of AAA.
And lung cancer.
Lung cancer screening using low-dose CT is recommended for men and women aged 50 to 80 who have a heavy smoking history, a 20-year PAC history or more, and currently smoke or quit within the last 15 years.
Finally, we have to understand the crucial public health surveillance mechanism: reportable diseases. These are diseases that, by state law, must be reported to state health authorities.
This ensures a rapid governmental response to outbreaks. Disease reporting is mandated at the state level, and the CDC maintains a comprehensive list of nationally notifiable diseases that states voluntarily report. This surveillance forms the early warning system essential for tracking outbreaks.
And our source material provides key examples showing the sheer breadth of this surveillance system.
We can categorize them by transmission type. You have STIs like HIV, syphilis, gonorrhea, vector-borne diseases like Lyme disease and rabies.
Water and foodborne diseases.
Right. Cholera, salmonella, E. coli. Then you have vaccine-preventable diseases like measles, mumps, polio, and finally, high-threat or miscellaneous diseases.
Like tuberculosis, SARS, COVID-19.
And agents with potential as bioweapons, such as anthrax and smallpox. The required reporting of these emerging threats underscores that epidemiology isn't just theory. It's the backbone of actionable global public health policy. We have completed a deeply technical but, I think, necessary tour of epidemiology. We started by defining how to measure disease occurrence with incidence and prevalence, moved into the rigorous metrics of diagnostic tests like sensitivity, specificity, and the prevalence trap, and then established how we quantify risk with RR, and NNT.
And then we followed that by detailing the objective hierarchy of study design, the meticulous phases of clinical trials, and the crucial necessity of recognizing and controlling for systematic error or bias.
And finally, we applied these concepts to real-world public health action, detailing the 4 levels of prevention and the precise recommendations for vaccination and screening.
So what does this all mean for you? You now possess the tools to move past sensational headlines and become a truly critical and informed consumer of all medical information. When you read a study, you can ask, was this a case control study using an odds ratio, meaning its conclusion is only associative and might suffer from recall bias?
Or was the sample size large enough to avoid a type 2 error?
Did the confidence interval include 1.0, rendering the finding statistically insignificant? You can dissect the methodology and judge the validity of the conclusion far beyond what the press release claims.
You're equipped to understand that an increasing prevalence of a chronic condition might be a sign of successful, life-extending care, not failure. Or that a positive result on a screening test might be a false alarm simply because the test is being used in a low-prevalence population. This understanding is the foundation of evidence-based practice.
We spent significant time discussing the prevalence trap, how predictive values change dramatically as the disease becomes rarer. Given that many diseases become rarer over time due to successful primary prevention efforts, better sanitation, health campaigns, vaccination, how should healthcare systems continually reassess the validity and utility of long-standing routine screening tests based on those shifting prevalence rates? If a test's positive predictive value drops too low due to a declining true prevalence, is the anxiety, cost, and risk of unnecessary follow-up still justified? Something for you to mull or explore on your own.
Thank you for joining us for this rigorous deep dive into the indispensable language of epidemiology.
We'll see you next time.